So we're going to get started in just a couple minutes.
Hello, everybody. Just a reminder that you can ask questions live in the chat. I will respond to them. And also in the Q&A.
Lori, can you see me?
Yeah, you're fine. I'm just off video just because
Okay.
I'm still here. Don't worry.
Okay.
And you look fine and you're bright enough.
Okay. Okay. Okay, we're going to get started. Good afternoon. There are over 400 residents and faculty from various universities who registered for this lecture, and both Dr. Cohn and I are honored. Special thanks to MedOptima for hosting this event. And for references, I would recommend you look at the International Dermoscopy Society site. There's an encyclopedia called Dermoscopedia, which is just a wealth of information. There are podcasts anywhere from 10 to 20 minutes. And there's another free site called confocal101.com, where it incorporates both confocal and dermoscopy in the evaluation of melanocytic and non-melanocytic neoplasms of the skin. This lecture is dedicated to my mentor, Al Koff from NYU, and a dear friend and colleague, Jane Grant-Kells. And we're going to continue on with our lecture on melanoma-specific structures and patterns. We spoke about this a little bit 2 weeks ago, and we'll continue on with that lecture and perhaps show some unknowns as well. But before doing that, I'd like to just comment on some of the dermoscopy devices over the past 25 years, teledermoscopy, and what I call the healers and truth seekers. My exploration with dermoscopy, my journey began back in 1996 when I purchased these two handheld microscopes, the Welsh Allen and the Heine. And myself with a couple of my colleagues, we began to create the language of dermoscopy, bridging the clinical with the histologic. Now, I was a zealot. Anybody who would listen to me speak or comment on what a great tool this was to be able to save lives, they thought I was crazy, a nutcracker, and they avoided me like the plague during this early period of time. And if you look even in our journals, there were comments that why do dermoscopy? Physician has a good pair of eyes and can perform a biopsy. Why do dermoscopy? But fortunately, over the years, that has changed. These were some of the dermatoscopes in the early 2000s. And this has been the major breakthrough, the hybrid scopes, where you have both polarized and non-polarized light. And just by flicking a button, you're able to toggle back and forth. And then we have our devices to store and document the images. And the digital cameras started to come around in the early 2000s. And we then had these dermoscopy attachments where we then could look at dermoscopy images with these digital cameras. And the quality wasn't great, but within a year, more cameras came out and more attachments, and the image quality became quite good. And these are some of the images from that 2005 group of cameras. Now, the big breakthrough, in my opinion, were the iPhones, the iPhone 4. So you had an iPhone 4, and if you could somehow attach a dramatoscope to it, you had the marriage of two novel instruments. And these iPhones were placed in either dermoscopy holders or connecting kits, and they really changed the game. So here we have this subtle melanoma on the back, and you can see not such an easy diagnosis to make clinically. With dermoscopy, however, it's easy. 2 weeks ago, we spoke about melanomas on sun-damaged skin. We spoke about the angulated lines, the polygons. This is melanoma on sun-damaged skin. Well, what else? We have the attachments now where you actually have a dermoscopy attachment, which you can actually place right on your iPhone. These are clip-ons. And these clip-ons, again, are changing the way we practice. So here we have a melanoma on the arm. And you can see with this clip-on to the iPhone, look at the quality of the image compared to the point and shoot camera. And this now brings up the role of teledermoscopy. Now with the clip-on attachment to your iPhone, you can send these images and in real time obtain answers in terms of how to manage your patients. And at the Medical College of Georgia, with Dr. Loretta Davis, who's the chairman of the department, they're initiating a large study with practicing physicians in rural areas of Georgia. The family practitioners are provided with an iPhone and attachment, and the dermoscopy images will be sent to the dermoscopist, in this case me, for diagnosis and management. So even though I'm in Florida, I could be in Carolina or Georgia or Texas with Dr. Cohn up at the University of Michigan or at Henry Ford and be able to practice teledermoscopy. And here is how it's done. An image is taken by the family practitioner. It's sent to the dermoscopist. And in this instance, we have a melanoma, shades of pink melanoma with these polymorphous vessels. And with minutes, I can give a diagnosis. So it's a new paradigm in terms of how to practice to be able to give care to individuals who might not have been able to get that care before. Finally, I'd like to just comment on what I call healer and truth seekers. And a healer is an individual with the ability to cure ails, be they physical or mental, and as physicians, we attempt to heal patients. And there's a saying that whoever saves a life is considered as if he saved an entire world. So every time I pick up an early melanoma, I feel like I potentially have saved a life. But we as healers, unfortunately, have our heads in the sand. I hate confrontation. I hate anything else other than be able to practice medicine. And in those instances, we need to have another group of individuals who I call the truth seekers, who seek to understand and give meaning when unfortunate events occur. And this is healthy. And these courageous truth seekers help to expose and hopefully prevent some of the actions that are committed by powerful groups. Now, a couple of years back, there was an article in the Blue Journal on corporatization and the rise of private equity in dermatology. These individuals who wrote that article, in my opinion, were brave truth seekers because they were trying to bring to the dermatology world what the possibilities are in terms of private equity's role and involvement in dermatology, whether it be good or bad. Our group was bought out by a private equity group, and it's been great. And it all is because of the CEO who's ethical and has high standards. But it was an important article, and it did get some controversial thoughts regarding the article. But in my opinion, these are brave individuals, and the article needed to be published. And then we have the Tuskegee syphilis experiment. It was a study to record the natural history of syphilis in hopes of justifying treatment programs for Blacks. It involved 600 Black men, 399 with syphilis, 201 who did not have the disease. And this was a major violation of ethical standards because in the 40s, we knew about penicillin and they did not receive this treatment. And it wasn't until the mid-60s that an epidemiologist from the Public Health Service who began interviewing patients realized this was wrong. He reported it on ethical grounds to the Division of Venereal Disease, both times rejected, and he then became a whistleblower, and it was only after it was published in the New York Times that there was a congressional hearing to terminate the experiment. Another truth seeker, Alan Hornblum, who published a book on acres of skin, human experiments at Holmesburg Prison, documented that a dermatologist conducted hundreds of experiments on prisoners for Johnson & Johnson Dow and the US Army. And it wasn't just testing diet drinks. It involved studies involving dioxin and chemical warfare agents, which went on for over 20 years until this was exposed. Now, we have activists out there who are concerned about 5G towers, 5G. Could this be dangerous to the public health? Well, these individuals really just want more research done before carriers deploy the technology. Is there a reason to be of concern? I don't know, but I do know that dermatologists in the 50s and 60s used ionizing radiation, Grenz ray radiation, to treat acne, resulting in hundreds of facial basal cell carcinomas. When I began my Mohs surgery back in the 80s, I used to see the unfortunate patients who had radiation therapy and had terrible basal cell carcinomas. And finally, the risk of rushing a COVID-19 vaccine. Telescoping testing timelines, approvals may expose us to unnecessary dangers. Could it happen? What happened with the developers of polio? Their original experiments were on children at handicapped children before giving the vaccine to so-called normal children. In those early years, there was the Cutter incident where roughly 40,000 people got polio with fever, sore throat, headache, vomiting, 51 paralyzed, and 5 died. So yes, there are concerns, and we really can't rush the emergence of these vaccines. This was yesterday published. Vaccine makers keep safety details quiet, alarming scientists. So I think we have to be really, really aware of what's going on in the world, even though I'd rather put my head in the sand. Well, enough of my rambling, and let's begin with our talk on the subtypes of melanoma. Last week, we spoke about chronic sun-damaged skin, as well as desmoplastic melanomas. And we explained that there were 4 different patterns that we see with melanomas on sun-damaged skin. This was pattern 1, which we went over 2 weeks ago. These islands of pigmentation at the periphery, consisting either of a network or structureless areas. And towards the center, you've got gray dots granules, scar-like depigmentation. And pattern 2, characterized by this tan structureless area granularity. Pattern 3, angulated lines. Angulated lines forming polygons is another type of pattern that we see on melanoma on sun-damaged skin. In pattern 4, it looks like a lentigo. You have the slightly curved lines, moth-eaten borders. This could be a lichen planus like keratosis. It isn't. It's a melanoma with a solar lentigo-like pattern. We also mentioned about the accentuated skin markings, the blotches. These are predominantly seen on the lower extremities. In Australia, they call these actually unstable lentigines. Truly, they're evolving melanomas in situ. And finally, on the lower extremities, it's not common to see a globular pattern in an older person. Histologically, it has distinct pathology, which is called nested melanoma of the elderly. And we spoke 2 weeks ago about desmoplastic melanoma, how it's an impossible diagnosis to make both clinically as well as dermoscopically. And we showed this slide, courtesy of Dr. Ashmar Goob, where you have here a concentric circle. It's one melanoma-specific feature, which you'll learn about when we talk about facial lesions. And if you biopsy this too superficially, it'll come back as a lentigo maligna. You miss the desmoplastic component, so you need, if you do a shade, to do a deep enough shade where you're getting dermis as well. So now we're going to begin our lecture for today on non-sun damaged skin on intermittent sun exposure. And we'll begin with melanoma in association with nevi and de novo melanomas. Now, these melanomas associated with intermittent sun exposure, there's an increasing incidence. There are a large number of nevi. 50 to 60% are associated with BRAF mutations, and they tend to be seen in younger patients. These were called BK mole syndrome patients, atypical mole syndrome patients, all different names. Now, they either are de novo or in association with nevi. So let's take a look at some examples of clinical and dermatoscopic patterns of melanoma in association with nevi. Here we have a 32-year-old man with this changing pigmented lesion of the left side of the back. We see two distinct patterns. We see this pattern, which is the globular pattern, and this pattern, which has melanoma-specific features. We would call this a globular, two-component disorganized pattern. This pattern is organized, this pattern is disorganized. And the structures that we see are the following. We see globules with perifollicular hypopigmentation. It's a pattern that you would see with a nevus with congenital-like features. And then you have melanoma-specific features. You have a blotch. You have some focal streaks, a negative pigmented network, and globules irregularly distributed. It's melanocytic because there's a network, there are globules, and there are actually streaks as well. There are multiple colors, light brown, dark brown, gray. Does it have some of the melanoma-specific features? The answer is yes. You can see streaks, this eccentric blotch, a negative pigmented network. And this is a melanoma in situ arising in association with a compound congenital nevus. Now, melanomas in association with nevi on intermittent sun exposure often have the following features. They have a negative pigmented network. They have shiny white structures, only seen with polarized dermoscopy. They have globules irregularly distributed and an irregular blotch. These to me are the two most important features, a negative pigmented network and globules irregularly distributed. And here we have an example of a melanoma in association with the pre-existing congenital nevus. You see the negative pigmented network and you see the globules of different sizes and shape. More examples, negative pigmented network, globules irregularly distributed. More examples. And here again, melanomas in association with small congenital nevi, a negative pigmented network, globules irregularly distributed, in the same pattern here. And it's a distinct pattern that we see with these melanomas in association with nevi. In fact, this was an article which was published commenting on the fact of the negative pigmented network and globules irregularly distributed. Now, a few years back, one of my fellows published a retrospective study. It was actually a poster at one of our American Dermoscopy meetings. And of 161 lesions with a negative pigmented network, 35% proved to be melanomas, 17% high-grade dysplastic nevi, and a small percent Spitz nevi. All melanomas with negative pigmented network showed at least one additional melanoma-specific dermoscopic feature. Finally, a third of the melanomas showing negative pigmented network were in association with the nevus. So here we have this gentleman, history of melanoma, negative pigmented network, globules irregularly distributed. Here you can see the confocal image, melanoma association with an intradermal congenital nevus. This 72-year-old man, history of melanoma, negative pigmented network, globules irregularly distributed, an atypical meshwork seen with confocal, melanoma in association with an intradermal congenital melanocytic nevus. So the teaching point is that sometimes these type of lesions with the negative pigment network and globules irregularly distributed, when you remove them, some pathologists will call these a high-grade dysplastic nevus or a congenital nevus with unusual features. We treat these no differently than a melanoma in situ in terms of margin. But the two important features are a negative pigmented network and globules irregularly distributed. Irregular blotch. This is another type of pattern that we see with melanomas in association with a nevus. And here we have this lesion, this changing pigmented lesion of the lower back. And here you can see these were the original images. You can see this is a pattern that you would see with the congenital nevus, with these globules and the milia-like cyst. And you can see the change. Now you have what's called a dermoscopic island or a blotch. So the structures we see are globules in this eccentric dark structureless area. It's a melanoma in association with a congenital nevus. Now, these have also been called dermoscopic islands. It's a well-circumscribed hyperpigmented area that differs from the remaining pigmented lesion. And if a lesion has a dermoscopic island, it's twice as likely to be a melanoma than a nevus, and a percentage of these are in association with a pre-existing nevus. So here we have an example of a dermoscopic island with this melanoma in association with a congenital nevus. Now, a melanoma can occur in association with any type of nevus. We're all told about the dysplastic nevus in association with melanomas. Many of my colleagues feel that we see as many melanomas in association with small congenital nevi as dysplastic nevi. In fact, one of my colleagues from Austria feels that this is the most common nevus associated with a melanoma, not a dysplastic nevus, but these nevi with congenital-like features. So here we have a young woman with a history of melanoma. She had this melanoma, and you can see the globules are regularly distributed, the negative pigmented network, the white shiny structures, and she had this melanoma as well. And these are the type of individuals you have to follow forever. Now in November, she developed another changing mole on her shoulder, and here you can see again, negative pigmented network, and globules are regularly distributed, another melanoma in association with the congenital compound melanocytic nevus. And then a few weeks, many months later, but a few weeks after her quarterly full body exam, she noticed another changing lesion and came down. And again, she has another melanoma in association with a congenital nevus. Now, as I mentioned, a melanoma can occur in association with any type of nevus. These are melanomas in association with dysplastic or so-called Clark nevi. It's a different pattern. These lesions tend to have what are called a reticular disorganized pattern more commonly, where you might see streaks. So you can see it's an atypical network. An atypical network in this melanoma in association with the dysplastic nevus. Here you can see an atypical network and streaks. And this is a different type of melanoma association with an intradermal nevus. Here is the intradermal component. We have these slightly curved or comma vessels in association with features that you'll learn about for a facial melanoma. Now, melanomas associated with intermittent sun exposure can also be de novo, that is not associated with a nevus. So here we have a woman who has hundreds of nevi, a sea of nevi, in this one lesion, which turns out to be a melanoma. And this is a melanoma. And this is a de novo melanoma. And this is a de novo melanoma. Now, here we have a de novo melanoma in a patient with few nevi. And this as well. And this as well. Now, if we go back to our woman who had this early melanoma and this sea of nevi, this was a new lesion. And the only reason why we know it's a new lesion is we had a baseline set of photographs. Now, what do we see? Well, the structures we see include this non-uniform or atypical network. You've got a slight subtle area of gray and some focal streaks. It's melanocytic because there's a network and streaks. There are three colors: light brown, dark brown, gray. It's asymmetric in pattern, therefore dermoscopically it's an asymmetric lesion. It has some of the melanoma-specific features, an atypical network and streaks, and is a reticular disorganized pattern, a melanoma in situ. So what are the criteria for de novo melanomas on intermittent sun exposure? Well, we see an atypical network, streaks, occasionally dots and globules that are atypical, and regression structures. And here we have your classic de novo melanoma, where again, you have this atypical network. An atypical network. An atypical network with a few globules irregularly distributed. An atypical network. So you can see there are different patterns for these subtypes of melanoma. Nodular or rapidly growing melanoma, melanomas that make my heart sink. This 48-year-old man, one of my patients, developed this papule on his back over a 4-month duration. Structures. What we see here is a blue-white veil. We have these pink and red globules, these milky red globules, and polymorphous vessels. It's melanocytic because there are globules. There are multiple colors. There's blues and pinks and reds. It has globules, so it's a melanocytic lesion. The colors we just mentioned. It's asymmetric in pattern, therefore dermoscopically it's an asymmetric lesion. And it has a globular disorganized pattern, a nodular melanoma. Now, nodular melanomas have specific patterns as well. They can be homogeneous or homogeneous globular disorganized. They can be featureless with polymorphous vessels. They can have shiny white lines, only seen with polarized light. They can be blue-black in color. They can be multicolored. They can be symmetric. They lack a network. They lack streaks, and they lack regression structures. So here we have 4 nodular melanomas with this type of pattern. You can see it's a distinct pattern where you have a blue-white veil or a homogeneous globularly disorganized pattern. More examples, same pattern. All nodular melanomas. And as you can see, a different pattern. And when they're amelanotic, you have to look at the vasculature. And for these amelanotic lesions, they tend to have polymorphous vessels and shiny white structures. Which brings us to the next subset, shades of pink melanomas. Now, these can be in the form of papules, plaques, or nodules. And there's usually more than one shade of pink, and can be pink, brown, pink red, pink blue, and pink black. And here we have a gentleman with 2 synchronous lesions, 2 shades of pink lesions, and you can see they're characterized by this distinct pattern where you have polymorphous vessels and a brown structureless area at the periphery. Both melanomas. This patient comes back 2 years later with this lesion and the same pattern. Polymorphous vessels and these shades of brown at the periphery. Another melanoma. So 3 lesions with the same pattern. Now the features that we see with these shades of pink melanomas are the following. The vascular pattern. And the most common vascular structures in shades of pink include vessels as dots, linear random vessels, polymorphous vessels, pink and red oval structures, and milky white areas. Vessels as dots. This was one of our cases where we have just vessels as dots. You can't make the diagnosis. I thought this was a squamous cell carcinoma in situ. And this is from Dermoscopedia. You can see it has the same pattern. So this is a biopsy diagnosis. You cannot make it. This is the only one I have in my collection because it's not the most common pattern that you see, but one must be aware that it does exist. Linear random vessels. These are also known as linear irregular vessels. This was our case, showing you these vessels, which are linear and irregular, in a similar case by Dr. Margou. Polymorphous vessels. And this is the most common pattern seen with these shades of pink melanomas. Here you can see this is 2 of our cases where you have vessels as dots, which is the most common of one of the 2 features, and these linear irregular vessels. Both of these are early melanomas. and you can see clinically they are shades of pink. Now, for these thick melanomas, you don't see vessels as dots. You see these bizarre, thick loop vessels, twisted, splintered, and irregularly distributed. And here is one of our cases, and this is a case that's on Dermoscopedia. Pink and red oval structures, milky red globules. These are often seen with melanomas that clinically are either thick or have the colors red or pink. Milky white areas. These are very subtle melanomas. They're characterized by this milky white appearance or scar-like depigmentation, but look at the periphery. You see the brown structureless area in all three of these. White lines. These are white lines seen with these shades of pink melanoma. Shiny white structures with these shades of pink melanomas. And finally, the brown structureless area at the periphery. So you can see here these vessels as dots and these brown structureless areas at the periphery. Now, this was a case about a year ago. It was a gentleman with a family history of melanoma, had a changing pigmented pink lesion of the right back. Now, with contact non-polarization, you could see that you have these polymorphous vessels. And you can zoom in on this area, you can see that your vessels as dots and some of these linear irregular vessels. But you see so much better for this type of lesion in the polarized mode because now you see the shiny white lines, the pink white areas, and the polymorphous vessels, a melanoma. Then we have the spitzoid melanomas. This was a 77-year-old woman, had this pink plaque of unknown duration. These were the features. The structures that you see are these white lines, shiny white structures, and diffuse vessels as red dots. Now, the most common clues include white lines, diffuse vessels as dots, shiny white lines, or polymorphous vessels. And in this instance, this was a 77-year-old man, and two of the giants disagreed. Marty Min felt this was a spitzoid melanoma, and Bertie Ackerman a spitz nevus, because in a different patient population, the two lesions can look, the two types of neoplasms can look identical. And there was an article published a few years back on white network and spitz nevi and early melanomas, and even the giants will disagree on some of these lesions. So here we have a spitz nevus, and here we have this lesion. Is this a spitz nevus or is this a spitzoid melanoma? We treat it as a spitzoid melanoma. And here is another example of a spitzoid melanoma with the white lines and diffuse vessels as red dots. Now, what about dark variants? Well, there are clues. We see asymmetric streaks at the periphery and an asymmetric dark structureless area. So here you can see some of these asymmetric streaks and these asymmetric dark structureless areas is spitzoid melanoma. In this instance, the same. Asymmetric streaks at the periphery with this asymmetric dark structureless area. And still another example showing you this asymmetric dark structureless area. Anything else? Well, there was an article in April talking about the clinical and dermoscopic features associated with difficult to recognize variants of cutaneous melanoma. And I have a couple of these, but not all. The desmoplastic melanoma, to me, there's nothing specific for a desmoplastic melanoma for this particular lesion. The milky red globules, this pattern can be seen with a nevoid melanoma, these milky red globules. And here, in this example, we have a balloon cell melanoma. I've never seen one. Or in this instance, in one of our cases, a primary dermal melanoma. All you really see here is this multiple colors, this homogeneous disorganized pattern. This was one of our cases, which was a verrucous melanoma. And this I've never seen. This is from the internet, an animal type melanoma. Anything else? Well, that concludes the lecture on melanomas. What I'd like to do now with the remaining time is show you some unknown cases of nevi and melanomas.
Harold,
Yes.
Somebody wants you to clarify the difference between homogeneous and structureless areas.
Okay. So homogeneous and structureless to me mean the same. Basically, the term homogeneous really shouldn't be used. It really should be structureless. And by structureless, we mean there's neither network nor globules. But when we first created the language, we would call things reticular homogeneous. We probably should have said reticular structureless, meaning no network, no globules.
Perfect.
Okay? All right. Case number 1. Is this 1, 2, 3, or 4? And write these down. I'll give you 10 seconds because these are all pattern diagnoses. Okay. So this 46-year-old woman recently diagnosed with cancer. Oh, by the way, I have to thank Dr. Grant Kells for annotating the pathology for all of these cases. This 46-year-old woman, recently diagnosed with cancer, had noticed her mole in her chest had become darker. Now, the structures you see include the following. We have this uniform network at the periphery and this central dark structureless area. It's melanocytic because there is a network. There are no melanoma-specific features. It's a reticular homogeneous pattern. In this instance, it could be called a dysplastic nevus with mild atypia. Nothing else really fits. If there was a diagnosis of a nevus, it would fit. A Clark nevus, it would fit. In this instance, a dysplastic nevus with mild atypia is the best fit. And what we see here is an acquired melanocytic nevus. We have this lentiginous epidermal hyperplasia with hyperpigmentation. You can see here some nests and some melanocytic hyperplasia confined to the dermis. And here we have what is called bridging of the nest. You can see the papillary fibrosis. There's no pagetoid spread, a benign lesion. Case number 2 is this 1, 2, 3, or 4. Okay, we have this 30-year-old woman insistent on having this nevus removed. What are the structures? We see diffuse dots and globules, nothing else. It's melanocytic because there are globules. There are 3 colors, light brown, slightly dark brown, and blue. It's symmetric in pattern, therefore dermoscopically it's a symmetric lesion. It has none of the melanoma-specific features. In this instance, a globular pattern, and it's a pattern we see with a congenital nevus or nevus with congenital-like features. And here's the histology of an intradermal congenital melanocytic nevus. You can see the dermal melanocytic nevus cells in the dermis and surrounding adnexal structures. Here one can see as well, they're interposed between collagen bundles as well as angiocentrically. Case number 3. Is this 1, 2, 3, or 4? Okay, so this 20-year-old's parents were concerned about a changing isolated mole on their son's arm. Never go as a 20-year-old to the doctor with your parents. You're in trouble. So the structures include the following. Central dark structureless area with a uniform network with dots on the network. There are no melanoma-specific features. This is a reticular homogeneous pattern. An acquired melanocytic nevus. And here we see the lesion. It's acanthotic at the D junction. In superficial dermis, you see some nesting. A nevus with congenital-like features, or perhaps a Clark nevus. Case number 4. Is this 1, 2, 3, or 4? So this 40-year-old woman noticed a change in a pigmented lesion of the right thigh. The structures. You have dots asymmetrically distributed in a non-uniform network, and this has been called branch streaks. It has 2 melanoma-specific features, an atypical network and atypical dots. This is a reticular disorganized pattern, and most suggestive of either a melanoma, or if the pathologist read this as a dysplastic nevus with severe atypia, I wouldn't fight him because I would treat this the same way. In this instance, a melanoma in situ, you have this single and aggregated atypical melanocytic hyperplasia at the D junction and in a pagetoid distribution. Here you can see some pagetoid cells and this irregular nesting. A melanoma in situ. Case number 5 is this 1, 2, 3, or 4. All right, 37-year-old man, history of metastatic melanoma, noticed a change in the pigmented lesion of the posterior leg. Is it symmetrical, asymmetrical? It's symmetric in pattern, therefore dermoscopically it's a symmetric lesion. And the structures, it's all network. Now, some of the network is perhaps a little darker, but it's still relatively all network throughout. There's no other feature. It really has no melanoma-specific features. It's diffuse reticular, in this sense, probably an acquired melanocytic nevus. And here we see it has this lentiginous epidermal hyperplasia with hyperpigmentation. There are some nests and some single melanocytic hyperplasia at the D junction. An acquired melanocytic nevus. Case number 6, I showed you, so we're going to skip this. I didn't realize that I showed this particular case. This was the melanoma in association with a small congenital nevus, so let's just skip through this. Case number 8 is this 1, 2, 3, or 4. Okay, so this 66-year-old man had a red scaly papule of the left arm. What are the structures? Well, we see a little bit of perhaps of a residual network, and we've got lots of gray dots granules, the regression structures. There are a couple, 4 colors, light brown, dark brown, perhaps 5, pink, white, and gray. It's asymmetric in pattern, therefore dermoscopically it's an asymmetric lesion. It has some of the melanoma-specific features. In this instance, reticular disorganized. This is not lichen planus like keratosis. This is a mistake. This is melanoma on sun-damaged skin, a melanoma in situ. And here we see the single and aggregated atypical melanocytic hyperplasia at the DE junction. And here you can see this irregular nesting and pagetoid spread, a melanoma in situ. Case 9. Is this 1, 2, 3, or 4? Well, this 53-year-old woman was concerned with a 2-tone pigmented lesion of the left upper back. Now, the structures include the following: dots centrally located in a uniform network that thins at the periphery. It's symmetrical in pattern, therefore dermoscopically it's a symmetric lesion. You can have slightly different colors, but the pattern is symmetric. It has dots on the network and a uniform network that thins at the periphery. There are no melanoma-specific features, and this is characteristic of a nevus. In this instance, a gentigo, where you have lentiginous epidermal hyperplasia and hyperpigmentation. Case 10. Is this 1, 2, 3, or 4? So the 62-year-old woman noticed a change with this pigmented lesion. Colors: light brown, dark brown, pink, white, and gray. It's asymmetric in pattern, therefore dermoscopically an asymmetric lesion. It has many melanoma-specific features: the negative pigmented network, the globules of different sizes and shape, the gray dots granules. Most likely a melanoma in association with the nevus. And here we see this melanoma in association with nevus. Case 11. Is this 1, 2, 3, or 4? Okay, 45-year-old man had this changing pigmented lesion in the back. Structures. It's a network. That's all that you really see. And as I've told you before, sometimes the network might be a little more prominent than other areas, but for the most part, it's a typical network. It's symmetric in pattern, therefore dermoscopically it's a symmetric lesion. Has a reticular pattern. A dysplastic nevus with mild atypia would be the best naming of this. And here it's read as a dysplastic nevus low grade. You have this lentiginous epidermal hyperplasia. Here you can see the bridging of the papilla, the sparse superficial perivascular infiltrate. You can see that there are cells, they're bottom heavy. You have some discohesive junctionalness and a low-grade dysplastic nevus. So that ends our lecture for today. In 2 weeks, I'm only going to show unknowns. We hope to show at least 40 to 50 cases. Are there any questions?
There's just an issue with the, I think the histology photos, when there's the annotations are getting cut off of the slide.
I saw that they were really magnified. I'm not sure why.
Okay.
I'll make sure that they're not like that for the next session.
Okay, perfect. So, now, okay, so we finished this talk, so then we're going to do just 40 to 50 unknowns in 2 weeks.
Yeah, so in 2 weeks, we're only going to do nevi and melanomas.
Okay.
And then in 4 weeks, we'll begin the non-melanocytic neoplasms. And then after that, we'll do more unknowns. And then I'll mix up the melanocytic and the non-melanocytic unknowns. Then we'll do facial, okay? Then we'll do acral and all the things that I hate.
Thank you so much.
Okay, enjoy the day, and I hope you enjoyed my rambling today. Have a nice day.
Bye.
Be well.